Heart failure is an incredibly difficult concept to master. It's actually going to take 3 lectures to get through it all. In this first lecture, we're going to talk about the pathophysiology and treatment of heart failure and see how the two correlate, pathophysiology to symptoms to management. In the second, we're going to talk about an acute decompensation and how you manage people in the hospital and in the intensive care unit. In the third lecture, we'll review how you bridge someone to transplant and then how you manage someone at transplant. Let's start off by starting with the pathophysiology of heart failure by building the circuit of the human body. We're going to use this to build a symptomatology. You have a right heart and a left heart. In between are the lungs. The left heart is then connected to the brain and to the rest of the body. After all, the whole point of the lungs and the heart is to get blood to the body. This then returns as the veins to the right atrium, and the cycle begins anew. Of particular importance is the brain and the kidney. We'll get down to the kidney in just a second. The idea of heart failure is that the pump breaks. And if you understand that fluid is going to back up before the pump, you can then begin to discern what the symptomatology is going to be. For example, if the left heart breaks, that is, you have systolic ejection fraction that's reduced, fluid can't leave the left heart. That is, it can't get to the brain, causing confusion. It can't get to the kidney, causing renal failure. But because the blood can't go forward, also means it's going to back up before the pump. And so if you have left ventricular failure, fluid is going to back up in the lungs. It's going to cause shortness of breath. Likewise, if there is a right heart failure, blood is not going to get through to the lungs to the left ventricle. If you have an isolated right ventricular failure, fluid can't fill the LV. If the LV can't fill, there's nothing for it to push forward. So you may have the same symptoms, confusion and renal failure. But blood is going to back up before the break in the pump. So what you're going to see is fluid back up in the periphery. You're going to see jugular venous distension as well as peripheral edema and maybe some congestive hepatopathy. But the pathophysiology of heart failure is an inadequate pump, either diastolic or systolic, and we'll talk about the difference in a second. But either way, not enough blood goes forward. And the major consequence occurs at the level of the kidney. So let's explore the kidney before we re-review the signs and symptoms of heart failure, as well as the difference between diastolic and systolic. It doesn't matter. Either way, fluid's not going forward. And if it's not going forward, it's not making it to the kidney. This is a drawing you're going to see an awful lot in this lecture series. It's the nephron with the loop of Henle, distal convoluted tubule, and the collecting duct. This is the renal artery bringing in blood flow. And here, at the thin ascending loop, you have the macula densa, the JG apparatus. And you learned in first year that this senses sodium content. That's a confusing concept, so I want you to ignore it. Instead, I want you to see this as a switch. And it only makes sense if you know it as a Katrina switch. I bought my house in New Orleans after Katrina. Contractors came in to try to flip it over fast. And I have a couple of light switches in my house where down is on and up is off. It's not one of those switches where you have 2 switches for the same light, so sometimes it's down for on. There's one light switch for this one light, and down is on. I'm making a big deal about it because if you try to use this advanced organizer and don't remember it's a Katrina switch, on is down, off is up, you're going to get confused. The JG apparatus makes renin, which turns on Ang2. And Ang2 then makes aldosterone. Aldo's responsibility is to absorb sodium from the urine back into the body. It loses K as a consequence. Aldosterone also happens to lose hydrogen ion and reabsorb bicarb. Not very relevant for our purposes in this discussion. And the reason why it absorbs sodium is so that aquaporin channels can do their job and reabsorb water, because water follows salt. This is the action of aldosterone. This is the action of antidiuretic hormone. But Ang2 does something else. Angiotensin tenses the angios. So let's work through this. Let's just say there's an isolated left ventricular failure. It's systolic, so there's no forward flow. The weak, floppy heart is trying to perfuse organs, but it can't. So flow to the kidney goes down. Flow through the renal artery goes down. The GFR goes down. Flow through the system is down. Not enough flow to increase the switch to off, so it stays at on. Renin is made, Ang2 is made, and aldosterone is made. More fluid is reabsorbed, overloading the patient. And the worst part is that Ang2 tenses the angios. This increases systemic vascular resistance. That weak, floppy heart, which couldn't beat against the previous resistance, now has more resistance to beat against. Weak, floppy heart, more resistance, less flow. This system is going to cycle over and over and over again, and the systemic vascular resistance is going to continue to increase. The amount of fluid is going to be continually increased, the amount that gets reabsorbed. So the person is going to get overloaded and vasoconstricted, and that weak, floppy heart won't be able to push against it. Fluid will back up into the lungs and they'll drown themselves, all because the body's doing what it's supposed to be doing. So let's use this principle to build the signs and symptoms of someone who has heart failure. Knowing that left heart failure eventually causes right heart failure, see the pulmonary hypertension lecture, let's just assume they occur concurrently, as at the same time. This is not someone who suffers a heart attack and has just lost left ventricular function. This is someone who has CHF for a long time. If fluid backs up before the left pump, you're going to flood the lungs. The lungs help you breathe, and if you have fluid on your lungs, you're probably not going to breathe very well. The signs and symptoms that are classic for heart failure are the triad of dyspnea on exertion, paroxysmal nocturnal dyspnea, and orthopnea. If you find all three in a patient, you're almost certain to have heart failure. If all three are absent, you have essentially excluded the diagnosis of heart failure. But remember, the heart is trying to pump blood to the brain. And so if you don't have enough forward flow, that is, they're in a low flow state, that's a buzzword for heart failure, you might get some altered mental status. But this isn't common. This certainly is. This is more of an exacerbation. This is essentially what you assess every patient every time. But as fluid begins to accumulate behind the right pump, you are going to see fluid back up into the neck, into the feet, and into the liver. And you're going to see, on a physical exam, jugular venous distension. You're going to see peripheral edema. You're going to see a congestive hepatopathy on LFTs in your labs, and the patient is going to feel abdominal pain. This is a cause of abdominal pain that people usually miss. If your bowel is full and edematous, it's full of fluid, it's going to hurt. And it may even cause malabsorption. The peripheral edema and the JVD are things that we see. The pulmonary crackles that we auscultate are a manifestation of the same fluid that causes dyspnea on exertion, paroxysmal nocturnal dyspnea, and orthopnea. And finally, the thing that's going to tip you off the most is the physical exam maneuvers that show you the result of left ventricular failure, which is going to be an S3 as well as a laterally and inferiorly displaced PMI. So when you see someone in the clinic or even in the emergency department and you're considering, does this person have heart failure? The questions you ask are abdominal pain, how far can they walk, do they wake up in the middle of the night gasping for breath, and can they lay flat / how many pillows do they need to sleep on? What you look for is the peripheral edema, which is going to also lead to weight gain. The cardiovascular exam showing an S3, which is auscultated with the bell, and a laterally and inferiorly displaced PMI, as well as jugular venous distension. We'll get more into the laboratory tests in just a second. So let's talk about when you suspect someone has heart failure based on these signs and symptoms, what tests do you order and how often do you need them? Here are your options for the testing for someone who you think has heart failure. The BNP is probably the best blood test we have for the diagnosis. If they are less than 100, the diagnosis is excluded. If it is greater than 500, the diagnosis is confirmed. Of course, there are things you have to watch out for. A person who is obese may have a normal BNP but still have heart failure. Think of the BNP hiding in the fat. And there are other conditions that lead to an elevation of the brain natriuretic peptide. Any stretch of the right atrium is going to lead to an increased release of BNP. So someone who has chronic kidney disease and dialysis who's floridly volume overloaded will have a very elevated BNP. Someone who has a new onset pulmonary embolism will have right heart strain and evidence of an elevated BNP. That's technically the heart failure because the right heart is in strain, which is basically right heart failure. But the idea is that if you have a BNP and your suspicion is heart failure, it's almost confirmed 100%, as long as you can't find another reason for it to be elevated. The EKG is not going to be that useful. What it does is it helps you assess for old infarcts and for arrhythmias. Because the etiology of heart failure doesn't really matter. If you have heart failure, you're going to treat it. But you do want to know if there happens to be, you have evidence of ischemia, or if there's a current arrhythmia you can fix to reverse the heart failure. The 2D echo is the best test we've got. This is the one what we as internists can use before we consult cardiology. What the 2D echo is going to show us is the difference between systolic, that is one with a reduced ejection fraction, and diastolic, heart failure. Diastolic heart failure is not the term anymore. Now it is heart failure with preserved ejection fraction. Easier to say diastolic failure. The echo is going to show us the stiff ventricle that's non-compliant and refuses to fill with blood. That's diastolic failure, versus the systolic failure with a weak and floppy heart. The 2D echo can distinguish the two from each other. Right now, the management doesn't change, but you can feel that likely changes are coming, since this is a weak, floppy heart that can't pump where the diastolic failure is a strong heart, but it just doesn't relax. It can't fill. That is one of the major distinctions and classifications of heart failure, whether it is systolic or not. The left heart cath helps us distinguish between the other two major distinctions in heart failure. That is ischemic from non-ischemic. And this is not hard to understand. If there are complete occlusions of coronary arteries or large vessel diseases, like 80% occlusion, you presume that it is ischemic cardiomyopathy. The left heart cath also allows for intervention and possible reperfusion. If you see clean coronaries in the setting of heart failure, you know it is non-ischemic. If coronary artery disease and heart failure, ischemic. If no coronary artery disease and heart failure, non-ischemic. The left heart cath is done because if it is ischemic, you can either reverse the ischemia or find other at-risk areas so that they do not infarct those areas too. The right heart cath is often done at the same time as the left heart cath. The left heart cath is an angiogram. The right heart cath is a swan. You measure pulmonary pressures. And what it does is help confirm elevated pulmonary pressures. Because an elevated pulmonary pressure is indicative of fluid backing up before the left heart. If you think you have left ventricular failure because you have crackles and you don't have elevated pulmonary pressures, that's non-cardiogenic. You want to ensure that what you found is indeed a cardiogenic pulmonary edema. The right heart cath confirms elevated pulmonary pressures in the setting of left failure. Now, let me just make this clear. You are not cathing the right heart and the left heart. You are catheterizing the left side, which means the arterial side, to look at the coronary vessels of both the left and the right heart. A right heart cath is a venous catheterization accessing the right side of the heart and the pulmonary vasculature. Right heart cath, pulmonary vasculature. Left heart cath, coronary vasculature. Let's talk briefly again about the different types of heart failure. I'm going to stay right here in this image. There is the difference between systolic and diastolic, floppy heart, stiff heart, ischemic, coronary artery disease, and non-ischemic, no coronary artery disease. All other classifications and causes of heart failure are irrelevant because the treatment is going to be the same, whether it's alcohol-induced dilated cardiomyopathy or ischemic cardiomyopathy or tachyarrhythmia-induced cardiomyopathy. The treatment is the same. And the treatment is based on the New York Heart Association classification. Let's talk about the NYHA and how you treat heart failure. This is patients still in the outpatient setting. The class of heart failure is going to drive the treatment. And you will see that as the class increases, the treatments increase, such that any treatment that came in above class will continue for the worst classes. New York Heart Association Class 1 is a person who essentially doesn't have symptoms. This person has limitless walking capacity, does not have dyspnea on exertion, and is the person you question, did they ever have heart failure in the first place? Someone who's this well maintained doesn't need a lot of therapy. They need only an ACE inhibitor and a beta blocker. We're not going to review the studies that demonstrated this stuff, but ACE inhibitors and ARBs essentially are both okay. For beta blockers, you're going to pick metoprolol or carvedilol. Pick those two. And then a third one, nebivolol, also works. A lot of studies done on metoprolol and carvedilol. Those are the preferred agents. New York Heart Association Class 2 are people who can walk a couple of blocks. They're very functional. They're not athletes. They're not going to be moving around a lot, but they have almost limitless functional capacity. They can walk a couple of blocks up a couple flight of stairs. They are not as good as New York Heart Association Class 1, but they can take care of all of their ADLs and a little bit extra. These people suffer from a little bit more fluid, so we're going to get the ACE inhibitor, the beta blocker, and you're going to add on a diuretic, such as furosemide. Furosemide more so than hydrochlorothiazide. The thiazides aren't great diuretics. The loop diuretics, furosemide, are more potent. So usually you will see someone on furosemide rather than hydrochlorothiazide, knowing that if you combine hydrochlorothiazide and a loop diuretic, you're going to get even more potent diuresis. As your class worsens, a class 3 New York Heart Association patient essentially can only handle their ADLs. They're going to have trouble getting to the mailbox and back. They're going to be able to walk around their house and just about that's it. These patients are going to be, of course, on the ACE inhibitor, the beta blocker, and the diuretic. But now they need additional support. Which you pick is sort of up in the air right now. But it's the one that's going to better control their symptoms and better control their blood pressure. The blood pressure goal in heart failure is as low as they will tolerate. So even a systolic blood pressure of 90 or 85 is acceptable if the patient improves mobility. New York Heart Association Class 3 patients get the standard therapy and they add on either spironolactone or isosorbide dinitrate hydralazine. Isosorbide dinitrate has been shown to have increased benefit in African Americans, spironolactone in all comers. Which one you pick is more about cost and medication compliance. Isosorbide dinitrate hydralazine is 3 times a day. Spironolactone is 1 time a day. So sometimes it is actually better to put everyone on spironolactone if compliance is an issue. As the blood pressure gets controlled, you must always have an ACE inhibitor and beta blocker and try to maximize these first. If you have additional blood pressure currency, you can start working on adding spironolactone and or isosorbide dinitrate. Class 4 patients are the ones who are the sickest. These are people who are of shortness of breath at rest. I want you to feel that you're going to continue each of these therapies, but you're now going to consider this patient for palliation. These patients need transplant and also will have chronically infused inotropes. These inotropes are bridges to transplant or a destination therapy. Get them a couple more years. You're still going to try to do this. Everything that came before is in class 4, but when they reach class 4, they are in trouble and they are about to die. This is where you start talking to them about end-of-life issues and seeing how much they're willing to go through to continue their life. What's also special about class 4 is that these patients do not get an AICD regardless of their ejection fraction. All classes of heart failure have to control the amount of fluid that gets on this person. So all patients are going to receive less than 2 grams of sodium chloride per day and less than 2 liters of fluid per day. Restrict the salt, restrict the fluid. Now, all of these treatments should make sense if you go back and watch that pathophysiology segment. If you don't have a lot of salt and a lot of water to reabsorb, even though aldosterone is turned on, there's not a lot to overload the patient. If the pathophysiology is poor perfusion to the kidney and angiotensin II tenses the angios, giving an ACE inhibitor reduces afterload and lets the fluid move forward. ACE inhibitors and angiotensin receptor blockers also reduce the amount of aldosterone produced, reducing reabsorption of fluid unnecessarily. Spironolactone is an aldosterone antagonist, again blocking aldosterone. All of these medications are designed to prevent the amount of reabsorption of fluid and how much the angios get tensed. And finally, symptomatic relief with diuresis increases the amount of natriuresis and with it, water that comes off. Isosorbide dinitrate dilates the veins, making there less venous return, less work for the heart to do, and hydralazine is also an afterload reducer. All of these medications make sense, and all of these interventions have been tested. in studies to prove their efficacy. The only one we haven't really touched on is the beta blocker. And the beta blocker has neurohormonal effects on the heart that reduce cardiac arrhythmias and has eventual long-term potentiation of the systolic function. So all of these medications have been proven in data to help patients do better, improve their ejection fraction, and live longer. The last thing for treatment we have to talk about is who gets an AICD, that is a cardiodefibrillator. As your ejection fraction reduces, you're at increased risk of particular ventricular arrhythmias. So people who get an AICD have an EF of less than 35% and who are class 1 through 3. You also get referred if you have a widened QRS complex. In order to have resynchronization therapy. It's more complicated than this, but if you've caught up with all the treatments so far, you at least can refer to cardiology and say, I think this person needs an AICD. Can you please double check for me? To summarize, I want to include what you would have in every heart failure note. What you are assessing for is their functional status. How far can they walk? How many flights of stairs can they climb? Have they had any weight gain? Because these patients are going to accumulate fluid and they're going to gain weight as a demonstration. You're going to do the physical exam, which is going to focus on fluid. You're looking for peripheral edema, pulmonary crackles, and JVD. You want to document the medications they're on, and you want to include what the ejection fraction is, whether they are systolic or diastolic, or both, the etiology being ischemic or non-ischemic, and any changes you're making to their medications today. Of course, include when their last echo was. That gives you this information. Okay, this was a long and hard one, but it introduces an incredibly difficult topic. And hopefully you're going to be able to use the information that you have in this lecture in the coming two to understand why we do what we do when we do it. This was supposed to be Introduction to Pathology, the tests you can use to confirm your diagnosis of heart failure, the signs and symptoms you might see in someone with heart failure, and how you treat patients based on their New York Heart Association class. That is Heart Failure 1.
We make these videos for free, and we need your help. Please donate, because without your donations, we can't make any more videos. Please donate.